We're here talking with Dr. Lester Rosen today, who was the president of the American Society of Colorectal Surgeons in 2006 and 2007. And I'd like you to start off by telling me the road that you took through the ASCRS to get to the presidency, and mention the mentors that were there for you along the way.
I was fortunate. I did my residency in surgery in Beth Israel in New York City. And the general surgeons there had very much of a colon practice. The most senior was a fellow named Leon Ginsberg, and Leon, as most people know, really discovered Crohn's disease back in 1932, along with Crohn's, who was a gastroenterologist. He was the surgeon, and he was very articulate. He spoke 8 languages, but most importantly, he spoke the language of surgery. And his mind worked like a CAT scan. Before that was even invented, he would quiz you on what layers you would find as you would operate on patients, without the use of that. They'd have prior histories. Most of his patients were reoperated on, and he sort of knew what was the dangers that lurked. And the other mentor at that time was Hiromi Shinya, who really brought colonoscopy to the United States, and I got involved in that interest early on. We were lucky enough to have an actual colorectal surgeon on our hands there who was, I guess, boarded in the way they did it, I guess, in the late 60s. And his name was Ira Barish. And the first time he watched me do a case, because they would scrub on our cases, they were called ward cases that we were primarily responsible as senior residents, and he started to get angry when he saw that I was going to put my hand down into the pelvis. And for the first time, he showed me how to dissect Waldeye's fascia and then Denon-Vieira without any bleeding. And it was that point, I think, that I realized there was a specialty, and I realized that there was a lot to learn. So I went on from there to Cleveland Clinic. That's where I am now. I went on to Leahy Clinic in Boston, and at that time, Marvin Corman was writing a book, and he had a tremendous influence in his training from the UK. And I learned a great deal from him about surgery and colonoscopy. I continued with John Collar, who was an excellent surgeon and colonoscopist, and of course Mike Weidenheimer. Mike was a skilled surgeon. He was also a great mentor, but he was very busy during his year as president. And the clinic was moving from Boston to Burlington, and Mike was shepherding that move. So I didn't see him as much as I would have liked, and I think he understood that, and therefore he arranged for me to go see his friend, Alan Parks, at St. Mark's Hospital. So I went over there for about 6 weeks, and I was lucky enough to see him operate and learn a lot about anorectal, including fistula, from him. Then I went into Allentown, Pennsylvania, and how I got involved with the society was a phone call. And basically what happened was that I got a call from someone I never met named Frank Tierkoff. And Frank was president of the society. He was from Erie, Pennsylvania. And he said, we were talking at our council, and we felt that you should start up this new committee on standards. Of course, I asked, what is that? And he said, they're talking about setting standards up in the specialties. So we hung up, and I did a little research. That was 1986. Wasn't much internet, if at all, at that time. And I found out that the Institute of Medicine was holding a course on guidelines for setting guidelines. So I went down there and met a few people, and came back and started a committee. And we thought a few things. We thought that we should write guidelines, not standards, because we realized standards was a legal term and would get us into trouble if we had standards. So we went to guidelines, which evolved into practice parameters. But basically we thought we would stay with our own sphere initially, which was anorectal. So we started on hemorrhoids and fissure and fistula, and I know you became involved in that as well. And we went into ambulatory anorectal surgery. But as we were doing that, at the same time, there was a prominent organization called the Agency for Healthcare Policy and Research. And it was really the first time in my life I realized that part of my vocabulary was going to become devoted to abbreviations, because they called it ACPA. Of course, now there's so many abbreviations, I don't even know when people give talks anymore what they're saying, you know. But ACPA was headed up to look at endorsing guidelines from specialty societies. But the background was that Medicare wanted to either pay or stop paying for things. Serendipitously, I'll just sidetrack, I did a colonoscopy on a patient because her mother had colon cancer, which was kind of an evolving idea. And I got a call from the chief of cardiology, really scathing, saying that, you know, I have money in my mind, and why am I doing that? And I got really lucky, as some people do. And it turned out she had a very early cancer in the left colon. And we resected her. She ultimately became cured. And he actually called me up and he apologized. And said that, you know, he would start thinking about that himself, because he sees a lot of people, you know, and I explained to him we're really looking at first-degree relatives. And with that idea in mind, I said, you know, we've got to get some guidelines for screening for colon cancer. And I went to the AHCPR meeting, and they also had a session on how to apply for a federal grant and get government money to set guidelines. So I thought the obvious thing was to do that for colorectal cancer screening, because it wasn't reimbursed in those days. So we set up a committee, and we wrote a grant along with a company in Washington that I'll get back to. And we had to do a lot of homework. I went and took a course at a place called the Moose Institute, which wasn't hard to bear. It was a trip to Jackson Hole. And a fellow was coming out at that time named David Eddy. And David was very instrumental in setting up these cost-effective algorithms that were very powerful and very much admired by the government to look at what the impact would be in screening. So I got a hold of some Medicare data and looked how many people in Medicare that were being screened, and they had a percentage database, as did Blue Cross Blue Shield. And we figured out roughly around 1990, 91, that about $1 billion was spent then on screening, and was it effective? So I wrote a letter to Kathleen McCormick and met with her, and she said, yes, if we would endorse a grant to study for colorectal cancer. And I brought it back to council, and it was approved. And at that time, they had a buzzword called pluralism. And that meant you should involve as many people as you possibly could, which is the right thing. So we called our GI colleagues, and to make it very short, we realized that we were about 2,000 strong at that time in colorectal, and they had 30,000 members. So rapidly, Dr. Sid Winnower from Memorial became chief of the whole thing. And that was a good thing. He was the most knowledgeable person, I think, in the country at that time on the literature. And I became one of the principal investigators. There were 3 of us. And we went ahead and wrote this grant with the company. And unfortunately, the company handed in the grant close to the deadline. And it was too close. It passed the deadline. So we missed the first round, and I think the government liked our grant so much that they had another round of it, and ultimately we got our grant accepted, and they gave all the societies $700,000, and then we proceeded to try to agree on guidelines along with government endorsement. And that was a long process. The highlights of that were reviewing 3,000 articles, of which we took 300, or 10%, that had some credible evidence, so thus begun evidence-based guidelines. And if you think a paper isn't really worth writing, your paper, could be included in guidelines such as that. And after we got to an agreement, we wrote a paper. The guidelines were published. And basically, shortly thereafter, Medicare approved payment for, under certain circumstances, for screening as well as surveillance guidelines. They also included that. And that's been modified over a long time. So in the meantime, our society, with my involvement, published about 5 or 6 guidelines, and then that went over to Mike Abel, and Currently, I think we have about 26 guidelines that we have strong. So it's just one of the facets of the society, but that got me involved, in a committee, and I was fortunate to chair it, and then that led me to council and then officer, and that's basically, how my pathway worked. There's many other pathways.
That's a great story, and I remember being in awe of what you guys were accomplishing as a young attending surgeon, and it took imagination and the willingness to say that we as a small society have a place in what our disease and how it's treated. So congratulations, that was a strong effort on your part. Well, tell me, what about the ASCRS you love most?
Well, you get a chance to reflect on that on many levels as you are ascending the officership, and also as you finish your presidency, you look back. I think the most important thing to me was to have a group of individuals that I could look forward to seeing, not only just at the national meeting, but in between, during committee meetings or other meetings. I actually, again, was lucky that I met at an early age Pat Mazier, who began to serve as a real impetus to the Research Foundation. And Pat involved me early on, I think yourself as well, and Tony Senegor. And as young people, we would meet in a different place every year, and you can get involved in the concepts of research and fundraising. And that was very new to me as far as the fundraising part. And Pat was a great role model for that Research Foundation. He had tremendous perseverance. And through that organization, I began to meet the likes of Harry Abkarian, Harand, and Byron Gathright, and others, Rick Billingham. And those friendships early on among ourselves and also our spouses, and for some people their entire families, was quite rewarding to me. That, I think, is the singular most important. The second was a number of role models as well, who served as a guide to the ethics and morals of the specialty, and you would see that every year. No funny business, no acceptance of any new type of surgery or technology that wasn't, at least based on some evidence. I think the seniors at the time were accepting of change, because we have had some major changes, but I was very much happy to be a part of that.
So what are you most proud of that you brought to the ASCRS during your presidency?
Well, it was a combination of things. Many of them were passed from one to the other, but towards the end of the presidency, we finally finished our website, which I oversaw. And I know Deb Nagel and Dr. Richard Billingham, they did a tremendous amount of work on that. And one of the first things I learned that the hits on the site, the most common hit on our site for disease was anal fissure. That was, I imagine a lot of people had the daylight scared out of them that we're going to cut your sphincter. But it was not only that, it was, I think, just the idea that we could take everything and coalesce it into one site to do much of the work of the society. I also think some of the things that I saw that had very little to do with was the Educational Endowment Fund, to try to get us self-sufficient, that Bruce Wolf initiated, and our role in the international sphere of colon rectal surgery, bringing more and more surgeons on as honorary surgeons and getting involved on the podium, those people who were making major contributions. So I think all that was something that I witnessed. I was very grateful for that.
So as a strong leader in our society, tell us what your concept of leadership means in the area of committee work and also of mentoring.
Well, there's an old saying that used to go around. My old neighbor was, congratulate not the first person who ate an oyster, but congratulate that person who convinced someone else to eat it. And I think in terms of mentoring, all our residency programs, headed up by fine surgeons, are convincing people that, to do the right thing, to operate the right way, to follow our patients the correct way, to bill the right way, which is quite important, and to, uphold those tenets that our early surgeons advocated when they took us out of charlatanry in the late 1800s into a real specialty in 1899.
So where do you think our society should be headed in the future?
Well, one of the things I said in my presidential address was that we had about 2,500 members at the time, 2,600, and 25% were active working members. Excuse me. So we have a real engine in our society. And I think where we should be headed is building more programs, training more physicians. There's only maybe 3,000 of us, entirely underserved. I think for many of the surgeries we do, in particularly anorectal surgery, we're all seeing patients that had been operated on an average of 4 or 5 times before we got to them. So I think that's one issue, increase the training programs. And the second is to continue to be mindful of good evidence and new technology, but we have a cost problem in this country. And I think if we continue with unsustainable growth for the things that we may do, we're going to be in a lot of trouble. So I think we have to proceed with technology very cautiously and make sure that things that we do are very much cost effective for the future.
So if you look at our current situation, you've led us through several challenges in the past. What do you see as our greatest challenge now?
Well, it's just an observation, but I think the greatest challenge, other than the educational and the training, is to make our workforce happy, make our physicians happy. When you speak to a lot of physicians, they're overworked, they're tired, at least the ones I speak to, and many of them are slowing down early on. Our forefathers didn't slow down at age 45 and 50, they slowed down at 65, 70, 75. So I think we're going to have to create a new environment for physicians to be able to work in a way that they feel acceptable. And I think the beginning of that has been in the relative shortened work week for the residents. I think I see that coming for physicians, that in order to have the intensity that is required as a surgeon, you're going to need a little bit of rest and recreation. I know that may sound unreasonable, but when I look at least in my own institution at the Cleveland Clinic, which is a wonderful institution, we have my chart, which means that every patient now looks at their own chart.
Right.
And they've converted to an email address that if the patient sees something on the chart for a question, they have my direct email address. So they could contact me directly. Part of that is a good thing. We'll see what the future brings. But I think with the internet and with all these social media, it's going to be a challenge. And I think we have to keep our physicians happy.
Okay. So your last question. How do you want to be remembered, and what would you tell our society today? Your own words, your own thoughts.
Well, I'd like to be remembered as being very grateful, really, for the privilege to work for the society and become one of its presidents. And, I have to be remembered how the society wants to remember me.
Any words for wisdom?
Society is my extended family. And I wish for the society what I would wish for my own family, which is, success and, just long-lasting success.
Terrific job. Thank you for all your service.